So, Tanner, I think on my side, we are live.
We should be on our side in just a moment. Yep, we're good.
So, Tanner, I think on my side, we are live. Okay, so we can go ahead and start. Tanner, I'm getting some echo from my side. I don't know if it's same.
No, you're okay now. I think that was me. I apologize.
No problem. So I have my PowerPoint up. And in the next couple seconds, we'll start. Okay. Good afternoon. This is United Medical ACO. My name is Kemal Erkan. Today is February 12th, Friday, our weekly session. We have Dr. Vinay Hosmane, one of our cardiologists from United Medical ACO. He's a good friend of mine. He's going to be with us. He's attending all of our ACO meetings, which we have Monday and Thursday nights. And today we wanted to update all of our patients on the cardiac rehab. That's going to be part of our discussion. And I have Tanner with me as usual. So before we start the session, I think the first one, you kind of know the format that we follow. So if you can introduce yourself first, and then I'm going to go ahead with a couple of the COVID updates, and then we'll come to your presentation.
Thank you, Kemal. Thank you, Tanner. I'm Dr. Vinay Hosmane. I'm a non-invasive cardiologist here in Newark, Delaware, and I'm also part of the United Medical ACO. I'm looking forward to talking to you about intensive cardiac rehab today.
Thank you. So, Dr. Hosmane, your practice is in Newark, right? Your practice location?
That's correct. It's technically it's Wilmington, Delaware, and I'm on Kirkwood Highway, just around the corner from Christiana Hospital.
All right. So in these events, we have several different guests that we actually hosted. So I'm going to actually just go back to the beginning. So in the two different categories, we do have our policymakers, and we have our physicians, and we have some of our partners who are joining us. So last week we had Valerie Longhurst, Dr. Jen Lee from DIN was with us, Dr. Rick Hung, the state medical director, was with us, and then Brian Townsend was one of our guests before November. And then we also have Dr. Barnett Smith from United Medical. We have one of our partners from Humana was with us, Dr. Jennifer Lecudo and Dr. Ergal. They were one of the, I think I missed a couple of them, but I'll update them at the next meeting. So we do have, we have our regular updates. So this is what's happening in Delaware so far, with 81,875 total positive cases. The number of new positives are decreasing, except that I think yesterday we didn't have the data. It was 2 days old, if I'm not mistaken. So the average did go up just slightly. So Tanner, if you want to cover, these are yours. Then we'll come back to the vaccine after that.
Sure. Yeah, of course. Thanks, Kemal. I think it's important that we continue to share those types of information coming from the state of the spread of the virus in the state, as we like to remind everyone that here with the UMACO, we do care for nearly 12%, possibly closer to 15% of Delawareans throughout our integrated multi-specialty health network. So it's really important for us to keep an eye on that and be able to share that information with our patients, as well as make sure we're keeping track of it, maintaining our own data internally for our patient population. Our providers see almost nearly 500,000 patients' appointments last year, and that accounts for a vast majority of Delaware. So looking at our own patient population data, we like to keep track of the positive trends in the spread of the virus with our patient population, So we do see a little bit of a bump there, although we're still getting data in and resulting those tests from the last week. So that while that is a little bit higher number in the trend that we have seen in the few weeks past, again, that's still early data. And that's kind of contributed to a little bit of a drop in the tests coming out of our EMR, or our electronic medical record, from which our providers are actually ordering these tests. So that could be contributed to a number of different things. I know we've discussed that a lot of patients are going to some of those public testing centers run by the state, like the curative centers, as well as maybe pharmacy centers to get tested. And sometimes that might not be initiated from the PCP's office, but we're making sure we're doing our best to accurately catch and document that data. So another way we'd like to keep track of that is through our percent positives, as well as possibly tests that could be positive. So tests that we don't see orders for documented. We're making sure we're trying to follow up with these patients to see if maybe they did go to a state testing center. So if the test wasn't initiated out of the EMR, maybe they had gotten it done elsewhere. And that way we can kind of follow up with them and get an accurate documentation of that test result.
So Dr. Hosmane, as you actually get these updates from our weekly meetings, so one of the challenges that we see is the way that we are coordinating patients and how we are getting the data in. As you know, the primary cares are the main responsible providers, and then the challenge of not knowing who's being tested, when they are tested, and who's following up, it creates a lot of issues for PCPs. But I know from the specialist side, you guys are going through some of those issues as well, right?
Yeah, definitely, for sure. I think everybody's trying to do the best that they can do. I mean, we're trying to take some lead, from the state of Delaware and trying to make sure our patients get tested. We're having a lot of, trouble, as you know, with getting vaccines for our staff and our patients. And I think, United Medical should be given a lot of credit as a private enterprise to try to, track our own patients, trying to keep our patients healthy, emphasizing that we need to do telemedicine, emphasizing that chronic disease management doesn't stop during the pandemic, and also, taking the lead in trying to get patients vaccinated. And I think this has to be, a group effort between specialists, primary care doctors, the state, and also an entity like United Medical. As someone who works privately, I like to think that sometimes private enterprise sometimes can do things a little bit better. We do appreciate what our leaders are doing in the state and local government, but I hope that our clients and our patients will find that what we're doing under the United Medical Network is not necessarily cutting edge, but we're using technology and we're using our vast electronic medical record and vast network of providers to try to keep everybody safe during this pandemic.
Yeah. So I think the integration is the kind of like the key, and that's something that in the last 12 years we spent a lot of time and we invest a lot into it. And also, state of Delaware has it's almost like a gift that we have a Delaware Health Information Network. DIN, Dr. Jen Lee was part of this program at some point, and not utilizing DIN properly. This would be the perfect time for the state to actually use the DIN, but it didn't happen. But we are trying to keep everyone kind of together because the same issue we have with the test, with the updates that you are going to see in the next couple of slides, we have those issues with the vaccinations now. So we try to give the updates on the vaccination with as far as what's happening, what's coming up, if there's anything new, similar to our physicians meeting. So Tanner helps me with these slides. So Tanner, you can go ahead with these.
Sure. Yeah, I wanted to start off with some news that we actually first shared in this event last week. Kind of taking a look at the third possible vaccine candidate here. As we all know, we've previously only been able to roll out the Pfizer and Moderna vaccines through the emergency use authorization from the Food and Drug Administration. So they've actually went ahead and they did apply for that. I believe it was this past week. We'll hopefully know in sometime this month, by the end of the month is kind of what I was seeing. So in combination with the two that are currently in circulation, this could be a big game changer, especially with some different administrative details, such as it's only a one-shot vaccine, excuse me, rather than the two that we currently see. Excuse me, sorry. So kind of just taking a look at, we are tracking, this is something that we're sharing on a regular basis, to kind of be able to take a look, compare and contrast what we know about the two current vaccines, as well as any others that might be coming in to circulation here in the United States. So with that Johnson & Johnson single shot vaccine, it was proven 66% efficient in preventing symptomatic COVID cases. And that goes to, I believe, 85% across all studies there for severe symptomatic COVID cases as well. So when it comes to storing and shipping, that's another thing that we like to keep track of, because that was a large difference between the Pfizer and Moderna vaccine. This one is more regular in the sense that it can be stored and shipped at that -4 degrees Fahrenheit. So in regards to the side effects, there's really not a whole lot different there. Our big differences are coming in the one shot and the one shot is the large difference. So that could be end up being
kind of that one shot actually is, we were kind of maybe undermining this or not knowing how difficult it was going to be for provider offices to keep track of the two shots, because the challenges are really coming through as every day we have different challenges that we have with those. I was going to ask Dr. Hosmane, in terms of the efficacy of the vaccine, are they, like, we put them side by side, but can we really, are they like apples to apples comparison between the like the Pfizer, Moderna, and now the J&J at 66%? Because I heard in the international studies, like the Turkey and Brazil, they had different results for the Chinese vaccine. Can't remember the name right now, but so are you able to make any comments on that one, Dr. Hosmane?
Yeah, from a cardiologist perspective, I'm almost like a little bit of a layperson. I'm not a virologist or infectious disease expert, but I would say if you're looking at both the Pfizer or the Moderna vaccine, patients ask us, should I get one or the other? You know, some people want one or the other. Maybe they have Pfizer stock or Moderna stock. But if you look at the efficacy rates, I mean, they're quite impressive. I mean, 95% efficacy for a vaccine, you know, in my career is pretty awesome. You know, if you go back and look at the flu vaccine over the last 4 or 5 years, the efficacy rate of the flu vaccine, kind of a ballpark, is probably somewhere between 16 to 48% effective. If you look at the CDC website, don't quote me on the exact numbers, but it's not as dramatic as we think, and we do get good results from the flu vaccine. So I think number one, 95% efficacy is phenomenal, and I'm not finding just anecdotally any much difference between the side effects of the vaccines, you know, that the patients are getting. So I think that's the number one take-home point. You know, number two, I would say that there was something recently in the news talking about the Pfizer vaccine may actually, you know, looking at antibodies in patients who've already had the vaccine, that those antibodies might actually help us against the new variants. So I think that's something to stay abreast of. You know, in terms of delivery, yes, the J&J vaccine has a little bit less efficacy rate, but still pretty tremendous, you know, compared to the flu vaccine that we're all used to. And having one shot, as Kemal alluded to, would really help us with the delivery of the vaccine, because we're really having a supply chain problem. You know, we're having a problem with mass rollout, trying to find enough people. Well, we have a shortage of people in the healthcare community as it is, and trying to pull people to unload this vaccine in a mass amount is a tremendous undertaking. The other point I'd like to make with this vaccine that we don't talk about much is, you know, a lot of our patients are very scared about getting this vaccine, and what if something happens? What I find pretty awesome is that the COVID vaccine actually has an app. You guys have probably seen the app via the CDC. So we have live tracking of this vaccine. When I got the first dose, for 2 weeks, every day they asked me my symptoms. And, you know, secondly, after the second vaccine, here it is 3 weeks afterwards, once a week, I'm getting a text asking me to track the vaccine. So we have a live vaccine tracker, and we've alluded to that before the United Medical, you know, internal meetings, that never before have we had live tracking of a product, a new drug on the market, or a vaccine. And I hope that gives people comfort that there's live tracking. And also, I think with the advent of social media, here we are on Facebook Live. I mean, if there was 25 people randomly here in Newark, Delaware, who actually had a very bad outcome. It's hard to hide that. If you believe in government conspiracy and things like that, you can't hide something like that. I think with our news media and Facebook. So I try to allay fears by sharing that with our
Sure.
clients.
Yeah, and we made the video from United Medical ACO with all of our providers being vaccinated, and initially there was this low acceptance, but I think we are getting through that. So actually, in the next couple of slides, we have this herd immunity and how we get to that point. So there are there's an article from Washington Post. Tanner and I, we were actually looking into this. So that kind of explains where we need to be. So Tanner, if you can explain these to us.
Right. So the idea of herd immunity is something that has been discussed quite a bit already. It's something that, of course, we're aiming to achieve, and I think that that's the ultimate goal here with the vaccine administration. So as Kemal was mentioning, we kind of took a look at this interactive article or report, rather, that came out of the Washington Post that really kind of gauges where we are with the administration so far, and then kind of takes that, projects it out, and kind of tries to figure out and identify where that herd immunity point might end up being. So currently, with the projected or 100 million vaccines or doses administered, is what the new administration was mentioning that they wanted to accomplish in the first 100 days. Looking at about 1 million shots per day, then everyone could be vaccinated fall time of next year. So that's what this is right here. This isn't saying that that's where we're at right now. This is a projection of where we could be if we wanted to be at that 1 million vaccines administered daily. So that's going to come out to be about 660 million doses, remembering that each person is going to need two vaccines there. So that comes out to be roughly our 330 million population here in the United States.
Which is going to, if we don't actually speed up that process, that's
it's quite some time.
Another 18 months, right?
Right. So correct. So there's still some work to be done here. And that's kind of where we're going into with the next part there, Kemal, where to get to herd immunity, it kind of is tossed around between 70 and 90% vaccinated. And we're actually working towards and above that point right there, where that projection of 1 million would take us to next fall, right? So we want to make sure that we're well above that point. As of this past week, our rolling 7-day average, we're at about 1.4 million daily, and that's what this is. This isn't showing by week. That number or that figure is on administered by day. It's something to note there. Yep. So that herd immunity, as I kind of mentioned, if we wanted to reach about 90% of our population vaccinated, we could accomplish that by this fall if we do kind of tread towards that 2 million shots per day mark, which is encouraging that we're headed upwards still. We're about 1.5 right now as of that last data that was reported. So there's just a couple of different scenarios here that we wanted to share that I thought were kind of interesting to take a look at, these different projections. Mm-hmm.
So this is at 70%.
This was at 70%, yeah. And that actually might be something, again, not being from a clinical background, just kind of taking this as it's presented to me, maybe something Dr. Hosmane could kind of talk a little bit more on. But the numbers that we're seeing, anywhere from 70 to 90% herd immunity is going to be a good mark that we want to reach. So at that same rate, if we are able to get to 2 million shots per day, that threshold for 70% or herd immunity in that case would actually be the end of this summer.
Yeah, from my standpoint, from medical school and public health school, the number 70% rings a bell for herd immunity. That's usually the number that's been, quoted in the textbooks and public health studies, and you'll hear some of our public health officials talk about 70%. From my perspective, we don't deliver vaccines here in the cardiology practice, but a lot of our primary care colleagues do. I mean, I'm of the personal opinion, if we can get the vaccine in the hand of the pharmacies, Walgreens, CVS, some of the private pharmacies that normally administer the flu vaccine, they're well equipped, to deliver the vaccine, store the vaccine, and how to advertise it. And the primary care physicians, OBGYN physicians, pediatricians, hospitals that are normally used to giving the vaccines, in my mind, that's the best way to deliver it. So I think a lot of our local physicians have applied to get the vaccine. Once they get it, we're going to deliver it. My colleagues are going to do this. A couple months ago, United Medical Clinic had the drive-through flu vaccine.
Mhm.
I'm sure you guys, hint, hint, you guys would be willing to do something like that for our patients. I think it's just a matter of getting the vaccine. Unfortunately, we have a lot of our healthcare providers who have not received the second vaccine, and a lot of our elderly population who needs to get it. But I think it's achievable to get 70% herd immunity, at least here in Delaware, if we have access to the supply. I hear all my primary care doctor colleagues have applied to give the vaccine. My father's a urologist. He's applied to give the vaccine to his elderly patients. And we just need the supply. And I think the medical community here in Delaware can figure out how to give the vaccine out.
Absolutely. Actually, right now with the phase 1B, we are already having those challenges, and I do want to kind of share that, the way that what we were expecting and what's happening. Now, I didn't really actually, other than just suffering not being able to change my address on my driver's license on the DMV time. So this is what happened. This is what's happening with the second dose now. So first dose patients were at DMV. Now, they were not given the next date, next time due date. So this system is so difficult to navigate to get an appointment. It's almost like a lottery. So you can't really just get them easily. So now they were waiting for 3 to 4 weeks. Now, instead of going to second dose for the same facility, the curative or the DMV, I don't know where that's going to be. Now they are being referred to their PCP. And I think that's not right, because PCPs were not part of that decision in the beginning, but we had responsibility to give the medicine, give the vaccine for the first dose, rather than trying to make it more convenient for someone who already got the first one, and then they are trying to get the second one now. We have to keep track of those. How the vaccine is being delivered is already challenging in terms of getting the, like we are the shipment comes to us, like last week we got, let's say, 100 of them. So that's the first dose that needs to be used. So next time they send us another 100. So if I use some part of it for the second dose, then now I'm going to keep track of that, which is almost impossible to have a proper management. And interesting enough, Delaware News Journal actually have this article. So none of these things we are not actually exaggerating our difficulties that we are having. So this is also now, even in the newspaper, everyone is talking about it. Now, we could have handled this a lot better. Unfortunately, that didn't happen. But we'll try to figure out what needs to be done in the next couple of months to help everyone to go through this. Now, Dr. Hosmane, you are in between your office hours. And we wanted to discuss the intensive cardiac rehab. Now, you're a cardiologist, you have your cardiology office, and then you have the cardiac rehab. So if you can actually go through this and then explain to us who would benefit from it, what challenges you have with the COVID, with this program especially, because you are dealing with a lot of elderlies with Medicare population. So we would like to know a little bit more about the program.
Sure, Kemal. Myself and Dr. Delaware, another local cardiologist, have a Dean Ornish intensive cardiac rehab program, and this is a program developed by Dr. Dean Ornish and part of his Ornish Lifestyle Medicine outfit out in California. And if anybody wants a little bit more information on this program, there's a great book by Dr. Dean Ornish called Undo It, where he details the elements of this program. So we have a intensive cardiac rehab program, 1213 Churchman's Road in Newark, Delaware, which is across the street from Christiana Hospital. We have our location there because when you're exercising or treating heart patients, it makes us all feel a little bit better that we're close to the hospital. And this program is called intensive cardiac rehab. First of all, cardiac rehabilitation is a program that's administered to heart patients, someone who's had a cardiac event. in the event, in the hopes that you try to reduce a second cardiac event. In essence, it's almost like secondary prevention. It's, in a way to think about it, is it's physical therapy for the heart. You're trying to strengthen the heart muscle, give the heart more blood flow, teach people about diet and exercise, try to get them to decrease smoking. And so this program, called the Ornish Intensive Cardiac Rehab Program, is cardiac rehab on steroids. And quite frankly, myself and Dr. Delary feel that this is much better than traditional cardiac rehab. And the program goes twice a week for 4-hour sessions for 9 weeks. And the reason why this program I feel is better, it's more of a lifestyle program rather than just tagging in, doing some physical therapy for the heart and tagging out. And the way the program is designed is that there's a 1-hour lecture every time a patient comes in. And that lecture predominantly is with a dietitian. And the dietitian actually serves a plant-based healthy meal, a heart-healthy meal. And we bring patients in cohorts of 10 to 15, traditionally prior to the pandemic. So patients will go through with a group of peers. So there's some camaraderie there, and they learn about healthy eating, and they actually eat a healthy meal. That's followed by stress management. And stress management is very important. We all hear that stress kills. Stress can cause high blood pressure, harden the arteries, increase your blood sugar. So 1 hour of stress management, that's administered by a stress management specialist, usually somebody who's trained in yoga, many hours of yoga training, mindfulness. And we have a mindfulness and yoga instructor come in, and they'll teach people how to breathe, how to recenter themselves, how to decrease their stress. And actually change how they respond to stress. We all have stress here, and a certain amount of stress is good to get us motivated throughout the day, but then there's a tipping point. The third part of the program is 1 hour of group support. How much love and support do people have? And when people have, cardiac disease, sometimes they don't want to go home and talk to the loved one about it. They don't want to burden somebody with how they're feeling internally. So we know talking about things and how you feel is good for somebody. So we have 1 hour of group support, and the Ornish Lifestyle Program will have somebody who's trained in counseling. This is not a counseling session by any means, but we have somebody with a master's of social work or PhD in psychology who will come in and just guide patients to talk. Again, it's not a counseling session. We're not trying to get your deepest and darkest secrets, but we really want to facilitate patients talking to each other. We had a patient of mine who went through this program who said, I'm a social guy. I have friends. I talk to my brother once a week. I talk to my kids once a week. But he says, Dr. Hosmane, after this program, I started talking to my person at the post office. I started talking to the checkout person at the grocery store. And he goes, it felt good to reach out and talk to other people. So it's kind of about, sitting with your fellow man and sharing how you feel and not being scared to share. And then there's also 1 hour of supervised exercise. And we have an exercise physiologist who's there, and they supervise heart patients to exercise, and everyone's going to exercise at their own level. So even though we may have a handful of patients in the facility, we actually cater the exercise. And the point of these 4 elements is trying to give somebody a skill set to take with them. Intensive cardiac rehab has the same indications or diagnoses that you need as traditional cardiac rehab. So this program is really good for somebody who's had a heart attack, somebody who's had stenting of the coronary arteries, somebody who's had open heart surgery, which means having a valve surgery or having coronary artery bypass graft surgery. Also, if somebody's had congestive heart failure with a low pumping capacity, they would also qualify for intensive cardiac rehab. And we also have an indication for chronic stable angina. Somebody who has chest pain or shortness of breath with exertion would benefit from this program. And the one thing I really find that's pretty tremendous about this program is when people go through this, you actually can see the results over 9 weeks, and we can see the results that occur, a year down the road. So, after 9 weeks, the Ornish Lifestyle Medicine Program actually tracks intensive cardiac rehab patients. And there's 31 centers around the country, and every quarter metrics come out. And when we actually see after 9 weeks, the patients will have a 10-pound weight loss. Their cholesterol will come down 20 points, their total cholesterol, their LDL cholesterol. We actually see 4 or 5 point reduction in blood pressure. So if you enter the program with a blood pressure of 130 millimeters of mercury for the top number, we'll see a drop to 125. We also see a 0.5 percentage point drop in your hemoglobin A1C, which is a measure of what your diabetic or your blood sugar control is over 3 months. So if somebody had a hemoglobin A1C of 7.5, when they get through 9 weeks of the program, it drops to 7%. We see depression scores or depression indexes drop 50%. We see exercise capacity go 50%. So time and time again, the numbers that we see, the metrics that we see in patients who go through this program, it's pretty tremendous. And we have patients who come in when they go through this program and they do the stress reduction, they do the lifestyle change with stress reduction, they shift to a more plant-based diet. We actually even see that their episodes of angina, their chest pain that they have with exertion actually decrease. And we also see clients actually get into a situation where they have to start decreasing their medication because their numbers start dropping. Their diabetic numbers drop, their blood pressure numbers drop, their cholesterol numbers drop. So they actually drop their medications. And we all feel as physicians that the use of lifestyle medicine with medications is the better combo to go, rather than just giving somebody medications. And we found that this program is actually sustainable even a year out if patients do some parts of this program. They may do 100% while they're there to learn it, but even if they're doing 25% or 50% of what they learn in this program, this carries through even up to a year or longer. And there's also some statistics with intensive cardiac rehab where the number of emergency department visits have actually gone down as well. Healthcare systems save money, patients save money. So we feel that during the pandemic, the intensive cardiac rehab is extremely important. And even without the pandemic, it's been important. And what happened during the pandemic is that we actually had to shut down. You don't want to spread COVID in a facility. We have a very large facility on Churchman's Road, and we can have social distancing. But last year, we actually chose to close the facility until we get a handle on COVID. How is it transmitted? How do we prevent it? So what we did is we actually started a intensive cardiac rehab program remotely through Zoom and telehealth. And as this slide shows, there were other cardiac rehab centers around the country, most of them traditional cardiac rehab affiliated with hospitals that actually went to telehealth. And early on in the pandemic, nobody got paid for telehealth. All of us did this as a free service to community in our patients, because I always say that cardiac disease, heart attacks and stroke don't wait for anybody. Cardiac disease is not going on lockdown with the rest of us because of COVID. So what we did is we actually did our cardiac rehab sessions remotely, and we've continued this throughout the pandemic. And we're actually going to start another session coming up at the end of February, beginning of March. And the nice thing is that the Centers for Medicare and Medicaid have actually recognized this program. So actually, it's now Medicare that's actually reimbursing us, as well as other centers around the country. So it seems that they've actually finally caught up after a year that telehealth services are the way to go. And going back to my point about cardiac disease doesn't wait. That's one of the reasons why we decided to continue with our program free of charge last year, and why we're kind of harnessing telehealth services to continue it. And this is a slide that you're pulling up. Where have all the heart attacks gone? This was in the New York Times back in April of 2020. And what doctors across the country, emergency room doctors, cardiologists, we were talking to our cardiology colleagues across the country, and everybody was saying the amount of heart attacks that are presenting to the hospital were actually decreasing. We don't really believe that heart attacks actually suddenly decreased because COVID showed up. What we feel is that patients suffered silently at home with heart attacks. There are actually some late complications of heart attacks that are pretty severe, that if you don't get your heart attack treated, you can end up with rupture of your heart vessel. You end up with a really bad heart pumping capacity that's beyond repair. And we've started seeing that around the country, where patients are scared to come in to the emergency department, and they're minimizing their symptoms. So we're encouraging patients to come in and seek cardiac care. We don't have a rash of patients who are coming down with COVID because they showed up at the emergency room. So I think that's something very important to note. In fact, in New York City during the pandemic, they actually found that the number of out-of-hospital cardiac arrests with people dying actually increased. So as the number of heart attacks presenting to the hospital decreased, the number of bad outcomes actually increased. So we're really encouraging our patients to reach out to your doctor, to harness telehealth. Chronic, one of the ways to prevent COVID and to prevent cardiac disease is kind of the same thing. We know patients that have diabetes, hypertension, obesity are more likely to have a cardiac event. We also know that hypertension, diabetes, obesity is also going to risk your chance of getting COVID. We've seen that nationally in numbers. We've seen that here at United Medical ACO when we queried our own numbers. What diagnoses give the highest risk for being hospitalized with COVID? And number one, I believe, was hypertension, and diabetes and obesity is there. So as part of getting awareness about our intensive cardiac rehab program, saying that we're here for patients, we're running cardiac rehab, cardiac disease doesn't stop. I also want to encourage patients to link up with your primary care doctor. If you're scared to go in, please harness telemedicine. And if you control your cardiac risk factors and get them treated, you're less likely to have a cardiac event. You're also going to make it less likely you'll have a bad outcome with COVID.
So just to kind of summarize the program, a patient of Medicare, twice a week, 4-hour sessions for 9 weeks. So someone is there, let's say if I'm there on Tuesday, it's 4 hours, I'm going to stay there?
Correct. So traditionally before COVID, when we were running a live program, the live program would run as twice a week, 4 hours. So you would come in 4 hours on Tuesday, 4 hours on Thursday. This is pre-COVID. And you would go through all these sessions and you would go through with the same patients. So you have a lot of camaraderie. And a lot of these patients are actually now friends now that they graduated the program. Now that we're doing telehealth and telemedicine for the intensive program, we've actually reduced it to about 2.5 hours. And so with intensive cardiac rehab pre-COVID, Medicare, Aetna, Blue Cross, all the big insurance companies were reimbursing it if you'd had one of the diagnoses that we talked about. Now for telehealth, unfortunately, it's just Medicare that's covering it. And we've cut the sessions to about 2 to 2.5 hours, and Medicare still covers it. There's a little bit of Zoom fatigue that happens, as we can all relate to. So we've been able to cut the program down a little bit for telehealth.
So here's what I'm thinking. So now 4 hours twice a week, right? So that's almost 8 hours, which is really great. So from the lecture that they get, the stress management, which is actually really important. And I have a personal question on that. So there's the support group, and then there's a supervised exercise, which helps them with them staying active. Now, on the stress management, so I think our dads are same age, right? So mine's about 80.
Yep.
And your dad, and unfortunately, both of our dads, or fortunately, they're very active, right? So now, if I'm imagining if my dad was to go to this program, so it would keep him pretty occupied. So right now he's renovating one of his homes, and he's not managing his stress, but he's increasing everyone else's stress level in the family.
For sure.
Right now we are going through a lot of internal fights. So I wonder if we can just not do that in Turkey as well as we do it here.
I mean, sure we could. I mean, if you look at it from a humanistic standpoint, a cardiology standpoint, what we did when we were offering this for free, we actually, we have a fixed cost. So we did actually offer it to some patients who were out of state, who didn't actually have the exact qualifications, but needed the exercise routine. I had a friend's mother who had diabetes, and she couldn't go to the gym. Her diabetes was getting worse. So you can harness telehealth across state lines, and we can sign your dad up from Turkey, and maybe my dad and your dad can meet online.
Well, speaking of that, also maybe our president will qualify almost. He's 79, right? 78, 79, Joe Biden.
Yeah.
So maybe we'll bring him to the program.
We can invite President Biden. The more the merrier.
So, well, Dr. Hosmane, this was very helpful, and thank you for taking the time and sharing this with us.
My pleasure.
Our goal is to make this more accessible, available. And, every time I hear people saying, oh, I never knew this, I never heard this, I'm like, we just expanded our access level to a different dimension. So we are almost like it's like a TV channel. So we are on with our providers, we are on our public patients, and we'll do as much as we can to make sure that we increase the awareness of our programs. And I'm hoping that you are seeing the benefits as well. I know you have to go, you have patients, so we'll probably have you over again in the next couple of months. And we have some other stuff that we are going to continue with. Tanner, thank you for joining us.
Yep. Thanks a lot. Thank you, everybody. See you guys later. Thanks, Kemal. Thanks, Tanner.
Thank you. All right. So one of our goals for today's the Friday session is, we have an agenda, right? Our agenda is we are representing private practices. Any private practice out there, they may not even know that I'm doing this on their behalf, because when I'm doing this for my practices, for my accountable care organization, everyone else is going to benefit from it. I'm speaking to those providers who are still struggling in the healthcare landscape on their own, which is almost impossible these days. So while we are doing that, and then I believe in the next couple of weeks, we'll have different guests coming from the state. We do want to bring another issue. Now, every time I do this, I get in trouble, but life is more fun when you're in trouble. So Medicaid. So we want to educate. Now, when we have this kind of setup where one of my employees from our team who's with me, normally when we would talk to them, in this case, Tanner lost his
losing power over here.
There he is. So in this case, when I talk to the business development and tell them what's the challenges that we have with Medicaid, and why we have the challenges and what can be done. Now, when we are talking about this, we may hurt some group of people's feelings, but that's not the intention. The intention is what it is that we have and how we can actually deal with the problem. So, Tanner, you prepped a couple of the slides. So,
and to your point, Kemal, I wanted to kind of get into like a little bit of an overview. So this is something that we mentioned that we wanted to talk about and discuss. So this was also going to be a good learning opportunity for myself as well. And we kind of just wanted to first start over a little bit with an overview, right? What exactly is Medicaid? Who's eligible here in the state of Delaware? And where the program's coming from and what that patient population consists of. So started to kind of take a little bit of look into the state of Medicaid in the state of Delaware. And that is, as of the most recent data that I could get a hold of, is roughly 27% of the state's population. And that covers about 247,000, almost 250,000 residents here in the state of Delaware. So what does that translate then into our patient population is kind of like what my next question was, what I was curious about. And that comes out to be, I think we talked about it was about 20%. Is that correct, Kemal?
From the ACO side?
Right, from the ACO side,
it's about 20% of our population that we have under the value-based contract.
Okay. And so the other part of that was also we wanted to kind of look at like how much resources, what is the state putting into this? So in fiscal year 20, it was roughly about 20% of the state's budget that we could find was going towards the Medicaid program, amongst other things. And we see that huge other category there that could also be contributing.
So, Tanner, on this side, on this part, I do want to actually mention a couple of things. So,
sure.
When I worked with Governor Markell in his transition committee in 2008, I was charged with the HSS part of it, and I had to kind of, this is 13, 14 years ago, so I had first-hand information on some of the stuff. What I didn't realize is that, one, how simple the state budget was, and two, how complicated the state budget was. So 1/3 of the state budget goes to the health and social services. And then in that, the biggest group is the Medicaid as their expense group. So as the budget is increasing, Why is the budget increasing? Budget increase, a state doesn't actually make, it's not a business, so it actually increases because expenses are increasing. And how these increases are happening is, well, the one big ticket item is the Medicaid population. Now, when we look at this number, you just mentioned 247,000 individuals in Delaware. I think that number is higher.
I do
That's
too.
yeah, that's the 2018, the official number, but I do believe,
Same with the budget, actually. I just wanted to quickly mention, because with that 18%, there had been increases to the expenses there in that and that side of the budget. So as you were mentioning, as that's increasing each year, of course, that number is going to increase.
We have a couple of the state committee meetings that we follow as a guest, so they may have some more up-to-date numbers, and if Anthony knows the number, he can text me, but it's getting closer to 300,000.
Mm-hmm.
So that's the state with 950,000 population roughly. So this is a huge issue, right? So now think about this way. 1/3 almost of our population qualifies, and this qualification here is just out of better term, lack of better term, is not a qualification, not a good thing here. Mm-hmm. Qualification means that you live under the poverty level.
Low income, correct.
Poverty level. So being poor is the qualification for this. Now, that's individually you can do much, but when you are saying that 30% of my population is Medicaid, and I'm so proud of that, I have a problem with that. Mm-hmm. So giving insurance for people who are in poverty is not something that we need to be proud of. Giving jobs and increasing their life standards is something that we need to be proud of. So the root of the problem is poverty. It's not like the lack of insurance benefits. Now, that's one side of this. The other side of this is what we are giving for this population. What it is that when you have Medicaid. Now, in the state of Delaware, we have 2 Medicaid providers, managed cares. One of them is MaryHealth. The other one is Health Options. MaryHealth is through MaryHealth, and then the other one, Health Option, is through Highmark. So they also have their commercial plans. Now, the population, in some cases, they don't even know that they have this benefit. There is very less accountability. We are part of this is part of our value-based contracts, meaning that we have quality metrics with this group of patients. So I'm going to give you an example from our bariatric program. I have a patient because, as you know, the daily case conference that I do, patient missed nutrition classes 5 times, 3 times, and you have no incentive to bring that patient in because patient has no accountability. So in the state of Delaware, and I believe in every other state in the United States, you cannot send a patient statement to the Medicaid patient. That's illegal. So it's protected. Now, Tanner, you have insurance through us, through our company?
Mm-hmm. Yeah, that's correct.
Well, you are paying big chunk of that on your own every month.
That is correct.
And not only are paying for that, every time you go, you have a copay. Mm-hmm. There may be something that you may have deductible. And then if you didn't pay those at the time of service, then billing company would send you a bill. Mm-hmm. So now take all those out. You don't pay for it. You don't have copay. You don't have deductible. You don't have co-insurance, and you cannot be billed by the healthcare provider. So
just for my
that's the world that we live in. Go ahead.
I just had a question, and this might be helpful for anyone listening as well. You mentioned the 2 insurance companies in which through you can receive Medicaid, essentially, correct? Mm-hmm. What is the process for that? So how would we mention what makes a patient eligible? When do they then?
So from once they have that poverty level, I think it's 120% of the poverty level, and then based on how many family members how many individuals in the family would determine that. So now in this case, in many cases, this is necessary, right? So we wanna separate where this is necessary versus where this is being abused. So the accountability is extremely important. So if you're not accountable, if you have nothing to lose, when you don't have any consequences, and you are giving some benefit, there is no value. So right now, let me just tell you this. So I don't go to the gym to work out. I don't. Okay. So you get YMCA membership for me for 1 year for my birthday that passed. So you spend a lot of money on that, right? Let's say this is an example. So, well, then what happens? It has no value for me. I don't use it. So there are different ways that you can, satisfy that, but not by giving me the free gym membership. So that's kind of very, very cliche, classic example of this benefit and the consequences. Do I want this, or how do I use this? Now, when you take the accountability part totally out of it, then you are actually creating this mess. And unfortunately, with the states, when the government gets bigger, not just for the state of Delaware, but as the government gets bigger, I see more and more and more these types of issues. We saw the same thing with the vaccine administration. Second dose became a big problem. They left the primary care out of it, and now they want primary care to complete the mess. That's not going to happen. That's not how we function. So you really need to actually understand how you can help the population. But when this patient doesn't know that they have this benefit, or they have no interest in this benefit, for us to just pumping this to the program, and then I'll give an example. If you have to pick a PCP, I believe, for your benefit. If you're a Medicaid patient, as long as you are eligible for the Medicaid, you can go anywhere. No one can actually deny care. If you don't have the right PCP on the card, that doesn't mean anything. So then you want to do value-based management, like quality management. So if you don't have the, in the equation we have, if you don't have each element of this equation doesn't have responsibilities and accountability, this just comes to the accountable care organization. And when I was teaching this program in 2009, one of the things that I put the patients in that mix, meaning that patients are part of this process, and you can't take them out of it in order to achieve higher percentages on the quality. You have to make them accountable. So if the patient is using, for example, some narcotics, and it's not prescribed by us, the patient cannot be treated any differently. So we still need to be responsible for their quality. So there are so many, like I have a patient, and you may think that I'm lying right now, but you won't, because you have the same data that I have. There's a patient who visited the ED, emergency department, in the last 12 months. It's one of the Medicaid patients, 42 times.
In the last how many months?
42 times ED. Like they go to the ED. It's just, ED is just like whenever they have something, they can go to the ED. There's no doubt. Now, interesting enough, hospitals are not unhappy about it because they get paid.
Right.
So, but then who's responsible for the quality?
Primary care.
Primary care, accountable care organization. Oh, your patient went to the hospital for 42 times. What did you do about this? Well, I know at least they went there for 42 times, but what are we doing about that, right? So are we telling the patient they cannot, do this, number one? Number two, are we telling the hospitals they're not going to get paid if the service can be done in the outpatient setting? None of those are happening. So while we are going through our series of the talk with the state, I do want to bring these issues up, because the amount of money that's being spent is our money from our tax dollars, and it's not meaningful. So when you want some meaningful results from these, you have to make sure that accountability is built in. And it's not just one side or one party. Everyone in that mix should be accountable. So unfortunately, in healthcare, the design of the healthcare, which was heavily regulated with the help of hospital systems, it always favors the hospital systems. And one of our goals is to stop the madness in that case. So we are.
I just wanted to mention that as you kind of were laying the groundwork here for this conversation, as we do go forward and have some more guests on, particularly from the state side, I think that this is a great point to then be able to reference and to go forward with this conversation. So we'll definitely be able to keep an eye on that and going forward, continue the conversation with our community, with the state leaders.
That's so important. So, one of the best outcome of the pandemic is we are forced to utilize all of the resources that's available to us. And I think the digital media, digital health and digital media is helping us a lot, because we normally wouldn't spend this kind of time for these if we didn't have COVID-19 in place. So it's one of the silver lining of COVID-19, as I always say, is now we can actually focus on these really important issues so that what we are trying to achieve can be possible, and also public knows about the issue that we are going through. So
I think not just focus on it, but really make sure it's at the forefront of everyone's mind, community, making sure everyone's connected and aware of what's going on.
Absolutely. So now we'll have, we'll be back next week at the same time for this event. But next week we have our live event with bariatric program with Dr. Erkan at 3 p.m. on Wednesday. We do, I believe, have an event. Actually, next week is the third one. So that's the only one that we have. So next week we have two events.
That's the only one.
And that's about it for today. Well, thank you for listening this session and being with us. We'll be back next week. So have a nice weekend. Bye-bye.
Thank you very much, everyone.